We have a quorum, so we're going to get started. Welcome again to all of you who have been attending these COVID updates from our Department of Otolaryngology at Jefferson. Tonight, we're resuming the series here. For those of you who have seen our previous webinars, you know that they're available online. We sent out in the invitation YouTube links, and we're happy to share them with anybody who would like. Part 1, 2, and 3. We did take a 1-week break, so these are from those previous 3 weeks. They're all in the invitation. Tonight, joining me for a return visit is my colleague Gersten Nyquist, as well as our colleague Elizabeth Cottrell. So we're very happy to have these speakers. As I've mentioned in previous webinars, please note the date. So today's date is April 23rd, and I say that because the information and practices around COVID are rapidly evolving. And if you were to watch this on our YouTube presentation at future dates, we want you to have the context of when we talked about these things because they are changing. I will say that this is a presentation that our department has put together to share our practices. We do not represent Jefferson as a whole, so just please recognize that. Mute your phones and microphones. We want this to be interactive in the form of questions in the chat. So if you have questions along the way, drop them in the chat box and we will answer them either along the way or at the end. I show you our department here led by our chair, Dr. Keene, to show you that we're a large department, and obviously we have been dealing with COVID on multiple levels, and that's why we think it would be helpful to share it with you. We've shared this word cloud before of different things we're thinking about, and we'd like to switch up a bit in the topics and dive a little deeper each week. And so we think the timely one that has been in the news recently is planning for reopening. So we're going to talk about that tonight. Tonight's emphasis will be more so on resuming elective surgery. If we do future webinars, we'll probably focus a little bit more on office operations. As we've done in the past, we review some data and some previous slides. So any slide that has a blue box around it is something that's been presented at a previous webinar. You can look at the date on that slide to see what those numbers reflect. So on the first night we did a webinar, I showed you this graph where the COVID cases in the country were 69,000. I told you that evening they crossed 85,000, and the United States became the leading country in the world in terms of confirmed COVID cases. Our subsequent webinars were a week later, where that number tripled, and then a week after that, where it doubled again. We were off last week, but if you go over the last 2 weeks, we went from 450,000 to 835,000 as of this afternoon. So it took us about 2 weeks to double that time, which is at least slowing of the doubling rate, but it is 10 times the total number of cases compared to our first presentation in late March, when we became the country with the leading number of cases in the world. You can see that our current death total is 42,500. We'll talk about that death total a little bit later on. The global cases by day, this is I'm not going back to the beginning, so this is our last presentation 2 weeks ago, when the total number of cases in the world were approximately 1.5 million with 91,000 deaths. And now we're over 2.5 million 2 weeks later. You can see with the graph, at least the new cases per day don't seem to continue to climb each day, but they are plateaued. So the doubling time has decreased, but there are certainly a large number of cases, and the number of deaths have doubled since our presentation 2 weeks ago. We'd like to focus in on our state and our region. So Pennsylvania 2 weeks ago had a total of 16,000 cases and 313 deaths. You can see the trajectory was still quite upsloped at that time. In the 2 weeks since then, we have just more than doubled and quadrupled, at least quadrupled, actually more than that, the number of deaths. What's nice about the graph, however, is again, it seems to be that we are hitting a plateau and perhaps even a decline in the total number of cases per day. So this was 2 weeks ago. We were 7th in the country in total number of cases at 16,000. You could pay attention to New York and New Jersey at the top where they were at 160 and approximately 50,000. Now, 2 weeks later, we're at 36,000 cases. New York did not quite double in that time frame. New Jersey did. We more than doubled. So we have a lower number, a slightly higher growth rate that earned us now the 5th state in the country. On April 2nd, our doubling rate in Philadelphia County was every 3 days. Our last presentation, we were happy to be cooling off with a doubling rate of every 4.5 days. And now we're even slower with a doubling rate of approximately 17 days. So there is some good news in this. You probably recall this from a previous presentation where we talked about the White House press briefing that had really sobering news where they told us we were flattening the curve, but even the flattened curve would predict 100 to 240,000 deaths for the United States. Fortunately, that was pretty quickly revised. So if you look on the left side, on April 1st, the estimates of total ICU beds needed was about 40,000. By April 9th, that was revised down. You might recall I said this is a different y-axis to the total number of ICU beds needed, about 20,000. So the curve did flatten. This is now real time looking back at the peak. So these are instead of projected numbers. We ended up with approximately 18,000 beds needed. So when they reprojected that White House total number of deaths, it came down to, I forget, it was like 60 to 80,000 deaths. And that now seems to be what we're on pace for. I presented the number earlier. We're at approximately 45,000 deaths for the country, and it's predicted that the trajectory will land somewhere over 60,000. That's assuming we keep the same pace and that reopening doesn't lead to spikes or second wave and other things that can unfortunately change the trajectory of these numbers. Here's Pennsylvania that we looked at before, and we showed again that between the first 2 weeks of April, the curve was flattening, and here's sort of the more real-time number or where we are now looking back. What's nice about these curves, if we follow them, we seem to be on the downsloping portion of a curve, which is pertinent when we start talking about reopening society and reopening our practices. We'd like to show you a timeline of events, of significant things that have happened since our last webinar. So on April 16th, the White House released guidelines for reopening the country. The day later, the American College of Surgeons, in collaboration with societies of anesthesia and nursing and hospital administration, released guidelines for restarting elective surgery. We're going to dive a little bit deeper into those two guidelines later this evening. April 19th, they passed a rule that not only is it, can you wear a mask in public, but now it's required for you to wear it to walk into essential businesses. Governor Wolf extended the stay-at-home order on May 3rd. You can see that there was an EUA, emergency use approval, for an at-home self-administered COVID test this week. And just this evening, the House approved a $400 billion package for small business and hospitals with part of that being intended to expand COVID-19 testing. So that will go to the president for approval. So in summary, the numbers show that we might be starting to come down from a peak. One of the problems with the projections is when you look at all these curves that I showed tonight, they always draw them out nice and symmetric, like it's a bell curve. We don't really have certainty that it will be a symmetric bell-shaped curve. And with flattening it, there's concern that we've sort of thickened it, if you will, that the tail end of this might be, or the plateau of it might be longer than we think. However, with the evidence that we're starting to come over the peak, attention is being paid, and it should be paid, to how we reopen. And of course, advice is that we do so carefully. If anybody caught the Global Citizen concert this past weekend, you might have caught that the concert ended with this slide of this African proverb that said, "For tomorrow belongs to the people who prepare for it today." So now is the time for all of us to start preparing for how we open our practices and how we resume elective surgery. And that's what our discussion will be this evening. Now, you know, everybody likes to talk about who's open, reopen. We want to be like others across the world. And so where are other countries at? Well, if you look at some of the harder hit countries like Spain and Italy, Spain is set to allow children outdoors. I mean, that's the limit of their ease of restrictions on April 27th. Italy is not set to start easing their lockdown until May 4th. Germany has opened some small businesses. We talked about China resuming some travel around Wuhan at the last webinar. And I pointed out that you have to pay attention to what reopening actually means in terms of restrictions. So in China, to travel, you have to have a government-issued app on your phone that is a contact tracer and will determine if you've had contacts who've had put you at risk of COVID. And if your app doesn't show the green light as shown here, you're not allowed to travel. When people travel, they're checked with temperatures, et cetera. So pretty tight restrictions still in place. As we talk about reopening our office, you know, it's good to think about where we are at as a baseline. Our very first webinar talked about our telemedicine strategy. So I invite you to look back at that. These are some numbers of what we're doing real time these past 5 weeks. So we switched to a quote patientless or virtual office starting on March 16th. So the first week here, these are the same numbers just displayed differently. The first week here would have been the week of March 16th. So we were still transitioning. The orange shows that we saw 300 patients live in the office that week. Now, in a typical week in March, comparing year over year, that number would be 1,200 or so. So we were already feeling the impact of concerns and restrictions related to COVID. If you look on the subsequent weeks, you can see that our inpatient numbers have dropped, or in-office numbers, the orange line, have dropped significantly, and we're only seeing approximately 40 patients a day in the office. We've transitioned almost entirely to telemedicine, and all the other colors, the blue being the biggest, are established patients, but we've increased our new patients and our post-operative patients telemedicine. Interestingly, if you look at the new patients, we went up and then started coming down. And one of my hypotheses is we're seeing less new patients in part because you're seeing less new patients, and because your offices are closed, patients are probably not even getting through the system to then be referred down to us. So obviously, there are patients who are sitting at home waiting for all of our collective care. I'm going to introduce briefly the CDC and White House guidelines for opening up in America. The basis of it are these gating criteria on this slide. So first, they talk about symptoms. your area has to have a downward trajectory of flu-like symptoms for a 14-day period, or COVID-like symptoms. And you have to have a downward trajectory of documented cases and tests. So it's not like you can just stop testing or test less to prove a downward trajectory. It also has to be that the patient's symptoms are going down as well. In terms of hospitals, you need to be able to treat patients within your normal capacity, and robust testing should be in place for your healthcare workers, including the emerging antibody testing, which is coming out as we speak. If you meet those criteria, I talked earlier about how we seem to be hopefully coming over this peak. So if we are, and we count day one as now, we're still looking at 14 days from now. The other date I would point out and remind you is that we're at shelter or stay-at-home orders until May 8th in Pennsylvania. So that's roughly 14 days from now. I don't see us truly opening until we get to a date like that. These are some guidelines. So what does the first phase opening even mean? Well, all vulnerable individuals, we'll talk about that definition in a little bit, should still shelter in place. There's still no gathering in groups larger than 10. There's still no non-essential travel for businesses. So I started the things that are probably most pertinent to us. There's still an encouragement to do telework. So we would still emphasize telemedicine. Senior living facilities and hospitals should not have visitors. So that will be in place still. This does say elective surgeries can resume. But note, it says in the outpatient setting. So the thought process is you get these patients in and out of the hospital, preferably surgery centers, so that they are not competing with capacity in your hospitals, and they're not passing through where the COVID positive patients still exist. If you get through that phase one without a rebound in cases, and you continue to have a downward trajectory for 14 days, then you can move on to phase two. You notice that you're still encouraged to do telework. You can now start to resume non-essential business type travel. So we think about going to meetings or other things. It still says that visitors to hospitals and senior living facilities should be prohibited, and elective surgeries on the inpatient side can start to resume. And the final phase, that one says social settings should not be more than 50 people. And the final phase is when you can start having visitors in your hospitals, and it seems to be closer to the normal that we are expecting. That definition of vulnerable individuals, it simply says elderly individuals. So I'll let others define that one. But the second one is a long list of comorbid health conditions that people should be careful of. And even in the final phase, although they're no longer advised to shelter at home, they are told to minimize social settings and continue to practice social distancing. So that's sort of the guideline of what we're facing going further. I'm going to introduce Gersten Nyquist now. He's going to pick up and talk a little bit more in length about the medical society recommendations for resuming elective surgery. Thanks, Gersten. Are you unmuted, Gersten? Gersten has to unmute.
Thank you, David. Sorry about that. Do you unmute me? Can you hear me, everyone?
Yep.
Great. Well, thank you, Dave. I'm trying to go back here. Can you push me back?
You're good.
Okay, I
take it.
apologize about that. Thank you, everyone. Well, we're all getting ready for elective surgery. We're going to have protocols in order to make it safe for the patients and safe for the healthcare providers. And the American Academy of Surgeons, Dave, can we advance? There we go. Perfect. Came out with recent recommendations that will help us. Can you hear me, Dave?
I can. I'm trying to get to the participants. Your camera's off, and I'm trying to control it, and I don't have control of it.
There we go. How's that?
There we go. All right.
Perfect. Okay, we tested it so many times. But we have guidelines from the American College of Surgeons that will help us prepare, and we'll use those guidelines tonight as a framework as we get ready for elective surgery to make sure it's safe. And I would encourage all the listeners out there to use the resources that are there. I outlined some of the academies and different societies that have put forth guidelines that will help you as you prepare for elective surgery and bringing back patients in the office. So number one, Dr. Cognetti brought up the important point of looking at the numbers. The numbers play an important role, and as the decrease in COVID-19 incidence is required in order to proceed with elective surgery, we'll be carefully watching the numbers in our region, and the region can vary, whether you're in Philadelphia, whether you're in Lehigh Valley or South Jersey, and so you'll be working in concert with your local healthcare officials and hospitals to determine if there is a downward trajectory, not only in terms of the numbers, but patients with symptoms. So watching the numbers is going to be important, and they put that timeline on for 14 days. No one knows exactly when that may be right now, but it could come as soon as 14 days. So preparing now is extremely important. As part of the awareness, you need to know what the diagnostic testing is available for your hospital and local system. So currently, we're using the PCR swab method because it's the most available and validated. And so preoperatively, we're testing all our patients within 48 hours of surgery to determine if they have an active infection. The false negative rates with this are high, potentially as high as 30 to 40%. But the actual numbers are difficult to determine because it may depend on where you are in the disease, where the disease is most active, whether it's the nasopharynx or the lungs, and how deep they got with the swab. So it's the best that we have right now, and the recommendations leave it as a loose recommendation based on what's available in your local hospital setting. So where we are, the PCR is really the one that is time tested and most validated. With regard to when to get the testing, we recommend within 48 hours of surgery. Now, the turnover time for many of these rapid tests is within minutes, 5 to 15 minutes for some of them. But I don't think we can expect everyone to show up the day of surgery and get a test, because what if it comes back positive the day of test? So I think you have to plan carefully when you're going to get the test so that you don't have a lot of cancellations and delays and inefficiencies. Where are we going with testing? It's hard to know. When you look at what protocols are being recommended in the future, potentially a combination of PCR testing and serologic testing will give you the best indication of what's going on with the patient. So the PCR testing telling you what's going on in terms of an active infection, and the serologic testing determining whether you have some type of immunity. And the combination of both will give you a good picture about what the patient's risk factors are. Not only is it for the patient, but we need to look after the healthcare workers. So I think we can see an increase in testing of healthcare workers as testing becomes more available, and testing in the post-operative setting for patients coming back into the office who may need debridements or scopes. Can we advance, David? So maybe in the future, this is not where we're at right now, but potentially in the future, we could be getting into combined testing with PCR and serology, so that if both are negative, you could proceed safely with surgery. If the PCR is positive, you would obviously stop because they have an active infection. If the PCR is negative, but the serology is positive, we need a bit more data on this because the data for serology is not really in. The serology will tell you if they have antibodies, but it's not FDA approved right now to determine if someone has an active infection. Great. And when we think about operating on patients, there's a certain risk not only for the healthcare workers if the patient's COVID positive, but the patients also. So this was a study in China with 34 patients who were COVID positive. They didn't know the COVID status at the time of surgery, and when they underwent surgery, they had major complications. These were rather large surgeries, as you can see over here on the side of the screen, but all patients developed pneumonia, and there was a 20% mortality rate. So excited as we are to continue and transition into elective surgery, I think we need to be cautious about it. And those patients who are most vulnerable are the older patients and those with medical comorbidities. So we have to be prepared. And the questions that we need to be asking of our healthcare facility are, do we have the proper PPE to do surgery safely? And what are the hospital resources? Dr. Cognetti and Dr. Cottrell later will talk about what is the proper setting. Is it in the ambulatory surgery centers? What's going on at your local hospital? Are there enough beds available? What's the staff availability? So looking at your local healthcare facilities is going to be extremely important. There's going to be a lot of patient issues that come up. The patients are going to have questions about coming to the office with the risks of COVID, the risks of surgery. So we need to be prepared to answer questions about COVID-19 and undergoing surgery. And I'm going to spend some time talking about surgical prioritization. So the AAO, our academy, and the American College of Surgeons both recommended a tiered framework so that as we prioritize surgeries, we want to get to those ones that are most urgent, as there's a risk of surgical delay would cause a problem in the patient. And we have to balance that with the fact that we're exposing our patients and bringing them out of social isolation and potentially contracting COVID, and the fact that the testing is not perfect and we potentially could be operating on patients who are COVID positive. Next slide, David. So when we look at risk, age-related mortality increases dramatically. So you can see this is data out of New York and the Northwell system, and there were approximately 5,000 patients that they looked at. And if you look down at the age, this is survivorship. So 63% of patients died who were admitted to the hospital. So not all patients, but those that required admission, 63% of males over 90 died for males. If it's 80 to 90, it was 60%. So you can see the elderly population, even patients over 60, 18% risk of death. So we really need to calculate carefully age of the patient when we make recommendations for surgery. Yeah, you can advance, David. And this is just additional data from around the world in the next slide. Showing the same thing, that basically as the age increases, the case fatality rates of patients who are admitted increases dramatically. So again, as we look at patients to bring in for elective surgery, bringing the elderly patients out of isolation and recommending surgery is a serious consideration as we move forward. Not only is age a significant risk factor, but comorbidities. And you can see the fatality rates. These are fatality rates of these comorbidities significantly increase the risk of having an adverse outcome. So we need to be very careful that we don't bring in patients, expose them to potential COVID in the hospital situation, because their risk of having an adverse outcome is very high. So there's triaging systems that have been set in place. I'd like to bring your attention to one of them, which is the MENT study out of the University of Chicago, which proposed a scoring system that included patient risk factors, the medical necessity, and the resource utilization to help guide us as we determine whether patients are safe and we should recommend surgery. So the scoring system takes into consideration the surgery itself, the length of surgery, the length of hospital stay, the blood loss, the patient's age and their medical comorbidities, and the options and need for surgery besides surgery options such as medical options. And it gives you a calculated risk about whether it's okay to proceed with surgery or maybe you should hold off. So when we prioritize surgery, there's some strategies that may help with successful implementation. And one is shared decision-making. Cases should be reviewed not in isolation, but with your colleagues. And you should consider some of your non-ENT colleagues to discuss this with. While we know the disease processes like sinusitis and sinonasal cancer and thyroid problems better, other medical comorbidities like hypertension and age may be more difficult. So you shouldn't be making decisions in isolation. You should be in close contact with your colleagues in the community to see what their experiences are so you can learn from that. I think it's very important that we establish committees or leaders for protocols, both in the office and in the hospital, so that we set up a safe surgical environment. And as the data is very fluid, we need to stay up to date with recommendations about what is safe practice. So we went through the exercise in the rhinology division of dividing surgery. So right now, in terms of surgical prioritization, we're really looking at the 3B and 3A tier, which are the sickest patients. As we move into this next phase, we really want to prioritize patients to those who have medical conditions that the risk of delaying surgery may have adverse outcomes. Now, you'll note from this proposed tiered system that everyone gets COVID tested. So right now, for the most urgent things, you still want to test the patients. For some of the more time-sensitive surgeries, and we'll give some examples, you may want to delay surgery for the COVID positive patient. And certainly as we look at the priority tier and the elective tier, those patients that are COVID positive, you're going to delay. So here's some examples of cases that are the most urgent and most emergent, things that you're not going to delay, but you're still going to get tested. Cases like an orbital hematoma, invasive fungal sinusitis, cranial neuropathies, or meningitis. I think it's helpful, whatever your area of interest is to develop a tiered algorithm so you can prioritize cases, because we all have a huge surgical backlog. Next slide, David. So as we move down the line to the less urgent surgeries, these ones too, within the course of 1 to 2 weeks, you want to get to these surgical cases. And this is what we're dealing with in the hospital right now, more of the time-sensitive type cases, cancer, bleeding that won't stop, complications from whatever the disease process is. These cases still need to go, but now we're moving into more of an elective phase where we want to prioritize cases. And the priority tier should be some of the sicker patients that we recommend surgery for. So we gave some examples here of inverted papilloma, odontogenic sinusitis, chronic sinusitis that may involve complications, massive nasal polyposis. So I think that the exercise of going through this tiered system will help organize your surgical backlog. And then as we get into the most elective cases, those patients that are not really time sensitive, I think you want to know that the safety measures in your hospital or surgery center are safe before you're going to introduce a patient to surgery. And these are cases that are not really time sensitive, they're more elective. And I think you want to make sure that your strategies are safe before proceeding with these most elective tier surgeries. So again, when you're coming up with your protocols for your local hospitals and surgery centers, you want to walk through a patient from the preoperative setting when you're evaluating them for surgery, considering the use of telehealth, limiting unnecessary contact with healthcare people like nurses and check-in staff, and just walk the patient through in your mind all the different steps and being involved in those steps so you have a safe environment for the surgery setting. And then once you've gotten through a number of patients, you should look back and reevaluate your policies to make sure that your procedures are safe and that patients are not having adverse outcomes such as developing COVID while they're in the hospital or ambulatory surgery setting, that your healthcare workers are not getting sick. And so you should be continually reevaluating whether your strategies are successful.
All right, thanks, Kirsten. Beth, you're up next. I'm going to give you control here. There we go. There we go. You make sure you're unmuted, Beth.
Yep, I think I am.
Perfect. Yep.
Excellent. So my name is Elizabeth Cottrell. I'm going to be talking at first a little bit about the Health Association of PA guidelines. Sorry, there's a little delay in my clicking. So these are guidelines that were published on the 21st, so just a few days ago. And I'm sorry, I feel like there's a little delay. I'm going to go back just a few. One moment. The guidelines state that no Department of Health action is required prior to resumption of elective cases. They are saying that basically surgeries can resume as long as there is adequate system planning. So it's kind of up to the region or up to even the specific hospital within that region. This is a statement that they put out that says new cases and hospitalizations, specifically from COVID, should be at a plateau or decline in the region. And they say for a defined period of time. As David and Gerson pointed out earlier, there are several sources that say for 14 days. This one doesn't actually define a particular number of days, but just says for a defined period of time. And then they say with an appropriate number of ICU and non-ICU beds, PPE, vents, and trained staff to treat all non-elective and elective procedural patients without resorting into these crisis standards of care. So in other words, being able to take care of the inpatients that you currently have with the possibility of a second spike and being able to proceed safely, not depleting your current resources. So the supply issues, you obviously want to make sure that the hospital has adequate ventilators, ICU beds, and medical or surgical beds. And then, of course, making sure that there is a continuous and active supply chain for PPE and, of course, staffing. And that would be staffing that is, not obviously having any symptoms. So continuing to do testing, and we'll talk about that in a little bit. So in terms of demand issues, we're going to potentially be prioritizing these cases into various categories, and specifically, just as Gerson had spoken about, for each particular specialty, and obviously for ENT, we're diversified sometimes in what we are tackling, whether that's cancerous, non-cancerous, ear stuff, neck stuff, kind of going all over the map in terms of whether we're exposing to the mucosa versus not. And we need to prioritize those patients in a relatively systematic way. Obviously, every patient is different, every situation is different, and so it'll come down to surgeons sort of making their decision. But as Gerson said, this needs to be done with a group and obviously talking with the patient and then potentially other providers as well. You want to adjust the OR turnover time to allow for proper disinfection. So this may be one of those times when those surgery centers are not actually running at their top speed, but actually taking the time to really truly disinfect as well as possible between those cases. Preemptively, they want you to identify only essential personnel to be present in the OR. For those of us in academic practice, this definitely means limiting the number of residents, certainly limiting or even eliminating observers. And then for devices or people who are coming in to help with, say, jaw reconstruction templates and things like that, we want to limit those people also as much as possible. One of the things that I wanted to sort of highlight was creating these capacity goals, which I thought was sort of something that hadn't really been addressed in any of the other guidelines. Sort of recommending that we begin with actually ambulatory cases before doing inpatient surgeries. And that's not maybe as intuitive when we're thinking about, well, these patients, they're sicker, they maybe need to go to the operating room more. And so you have to weigh those truly time-sensitive diseases against how you are flexing the system, and being able to utilize a totally outpatient surgery center, as David said earlier in the presentation, not only does not maybe pull from the resources that are in a main hospital setting, but also prevents those patients coming into that surgery center from being exposed to a potentially more high-risk area, such as even just going up in the elevator in the main hospital. That's a more potentially high-risk area than walking into a surgery center. And so you want to think about, again, those areas where patients and their families or their support system is going to gather or pass through. We want to think about decreased demand on that inpatient system resource. And while there are ventilators at surgery centers that are sort of in the bank in terms of mobilization possibilities to a main hospital if needed, as long as the overall number of ventilators and the staff to run those ventilators is at a good level for your particular system or your hospital, that's one of the things that they want you to kind of take into consideration. And then planning for kind of an eventual and gradual sort of ramp up rather than slamming them all on the first day. In terms of testing, HAP recommends that if it's widely available, to consider testing all pre-op patients. And certainly we have seen in all of the other recommendations that is truly something that, especially for otolaryngology procedures, and truly for any patient that's being intubated, we really do recommend. If those resources become limited, then the healthcare system has the obligation to determine a prioritization plan. And they don't really go into that too much, but one of those things that obviously we will need to consider if that ever becomes the case. I wanted to pull out also this quote, that widely available testing can serve as an important intervention, but they say, however, its limited availability should not necessarily prevent the resumption of procedures when a plan is in place for maintaining safety. And they specify safety of all people involved, patients and healthcare workers. So in terms of the environment, they want to ensure social distancing and, of course, facial coverings in the facility. And they said specifically in visitor and common areas. I added here in all areas, because I think a lot of places where we think about, the family waiting room or preoperative holding area, things like that, we don't really think about some of those common places like the hallways and elevators where patients are passing in more close proximity or standing in more close proximity. You need to have procedures in place for disinfecting all of these areas, and we all know that our hospitals do get disinfected. There's lots of staff that is dedicated to that, but this may need to actually be ramped up in some sort of way to increase the amount of disinfection that's going on. These are kind of my notes in terms of thinking about how some of these things might also play out to very specific recommendations, potentially limiting the number of support members. We know that for inpatients, there will continue to be a limitation on the number of visitors, as David pointed out in the phase 1, 2, and 3 plan from the White House, but specifically the people who are coming with a patient on their day of surgery. If it's outpatient surgery, maybe we should be encouraging the patient's family member to actually just simply drop them off and pick them up rather than staying and waiting in the waiting room, just to decrease the number of people that are even in that waiting room in the first place. And then we should think about reconfiguring those family waiting areas or common areas so that there's spacing of chairs, for example, there's consistent decontamination, and then there's barriers and plexiglass, that sort of thing in place. So I wanted to go specifically through a couple of recommendations from an endocrine surgery side if we have time. It's already 8:45. What do you think?
I think you can go quickly. I don't know where these words and lines are showing up on the screen from.
Me either.
So go ahead quickly. If I would encourage people with questions to start populating the chat now, and we will adjust accordingly in terms of time left.
Great. So this is kind of a conglomerate of statements from the American College of Surgeons, the AHNS Endocrine Surgery Section, and the American Thyroid Association. And I thought I would just sort of go through thyroid, similar to how Gersten went through rhinologic procedures, to kind of present a little bit about another sort of area where we have things that sort of fit a lot into that middle or second tier. So all of these societies do recommend pre-operative COVID testing for all patients, even though this is not a mucosal surgery unless you're doing transoral vestibular thyroidectomies, but otherwise they are not necessarily going through the mucosa, but they still will be intubated, obviously. Their recommendation is that those endocrine cases that do warrant urgent surgical intervention include thyrotoxicosis with life-threatening or severe symptoms that cannot otherwise be controlled with medications, goiters with airway compromise or symptomatic tracheal narrowing, and then thyroid cancers with an immediate threat to life or health, which we all know is a very, just a smattering of thyroid cancers. It's not the majority. So these are going to be ones with concern for invasion of extrathyroidal tissue, specifically the recurrent laryngeal nerve or trachea, the esophagus, or carotid encasement. This may also include, I would say, medullary thyroid cancer, which does not behave at all like many other thyroid cancers that are well differentiated. And then it also should include open biopsies, specifically for anaplastic thyroid cancer if a diagnosis cannot be made via needle biopsy or core. And it should also, include concern for thyroid lymphoma. So endocrine cases also include parathyroid surgery with life-threatening hyperparathyroidism. In other words, hypercalcemia that is causing such significant issues that the patient is at risk. And this usually occurs over 13 to 14, but can be even higher. And these usually cannot be controlled medically. And then pregnant patients also represent a different cohort. So hyperparathyroidism in a pregnant patient is actually a high risk to the fetus, and there are a couple of other smaller things. So the things that do not warrant urgent surgical intervention would be things like T1 and even T2 well-differentiated thyroid cancers, papillaries mostly. And we should also note that nodal disease from papillary is also often stable for years. This is just a slide with a couple of references, specifically papers from Ito et al. These two papers here discussing how cervical lymph node metastases after thyroidectomy for papillary thyroid cancer are often stable for many years. And then the slow progression of microcarcinomas, micropapillary carcinomas. This paper here came out from the Memorial Sloan Kettering group and specifically Mike Tuttle. And I wanted to pull out kind of this sort of reassuring statement about their data that during a median active surveillance of 25 months, so 2 years, they saw growth in tumor greater than 3 millimeters only was observed in about 3.8%. So about 4% of these patients are having a growth of 3 millimeters or more in 2 full years. So the cumulative incidence was 2.5% over 2 years and 12% over 5 years. So we can see that that does increase over a long length of time. Hopefully we're not going to be in this situation for 2 or 5 years. But when we're thinking about pushing off our patients for 9 months or 10 months, even a year, we can do that with some certainty that as long as we're keeping an eye on those patients, there should not be a significant risk. And there was no actual regional or distant metastases that developed in all 291 of these patients during active surveillance. I should point out that these were cases where the thyroid cancer was always papillary and was always 1.5 centimeters or less. So this is T1A and T1B papillary thyroid carcinomas. So this is, again, the tiering system. This is that ESAS And I just kind of pulled this up to sort of go through without any particular case here, but also specifically to kind of point out where they recommend these surgeries happen. So HOPD is hospital outpatient department, and ACS is ambulatory surgery center. So some of these tier 2A and 2B surgical patients really you should be considering, if you're doing a lobectomy or a low risk parathyroidectomy, minimally invasive, for example, those may be very appropriate patients to be doing in a surgery center, not having them ever come into the main hospital. They're able to recover at home. They're not utilizing overnight patient resources. They're significantly decreasing the amount of PPE that's going to be used, et cetera, et cetera. So that is the end of my talk, and we can begin.
All right, I'm going to take control back, please. For some reason, there we go. Okay. All right, so we're going to see the chat. Do you have time to discuss in detail how do you plan for preparing your office to see patients? How are you? Who's controlling the mouse? Okay.
Sorry, I think I am. I'm going to stop my remote control.
Okay, thank you. So the question is, do you have time to discuss in detail your plan for preparing your office to see patients? How are you going to disinfect, scope, and clean rooms? So we are actively have a work group addressing those things now, and we plan to do that in detail, hopefully at our next webinar. And Dr. Downey appropriately identified we have Zoom bombers, and hopefully nothing obscene pops up. Agreed. What criteria would you use to see patients in the office who have recovered after testing positive for COVID? So we generally go by the guidelines of our institution, and they seem to have migrated a bit as different tests have become available. And I guess the best thing that we can compare to is looking at how they return our employees. Right now, with our screening process and other things, given the time frame, we would, unless patients really, really needed to be seen in the office, if somebody screens with symptoms concerning for COVID and or tell us that they're COVID positive, we would try to keep them out of the office with telemedicine. If they absolutely had to be seen in the office for something urgent, then we would don the appropriate PPE. We don't have strict guidelines in terms of time frame between the two yet. I think that plays into the other question of how do you truly open the office? And those are the things that will be important as we try to expand from what we're doing now, which is essentially telemedicine gateway, to a more normal operation in terms of patients being able to call and just come in. The next question is endoscopic sinus surgery an aerosol generating procedure? Absolutely yes. If pre-op COVID tests carry a 20 to 30% false negative rate, do you treat all cases as positive? If yes, do you do FES with a PAPR or an N95? And Kirsten, I don't know if you want to address that one.
Sinus surgery is an aerosol generating procedure. Because of the high false negative rates, we do don certain PPE precautions above and beyond what we normally would. Currently, we always wear an N95 mask with face shield. Even in a COVID negative patient, everyone in the operating room does don the same level of protection. And we don't use PAPR for routine negative patients. If the patient was positive, then we would prefer to use PAPR, although that is institutional dependent. Some people don't have PAPRs available, but in the negative patients, we're using N95s.
I think the whole thing in an ideal world, it all comes down to testing and how good our testing is. And as Kirsten said, even though there's a negative COVID test, there still could be false negatives, and everybody is treated as positive, but only if they are positive. It's almost putting your head in the sand. If they are COVID positive and they absolutely need surgery, then we use the PAPRs and the rooms get covered up and everything. But I think a lot of these questions everybody's asking is going to be dependent on how robust the testing is that we ultimately have, both in identifying people who are actively infected but not symptomatic, to isolate them, and for being able to see patients in the office and in the OR with accurate testing, and whether that's serologic combined with the PCR is not known yet what we're going to be looking at.
Yeah, and just to add in what Mark said, I think it's important to understand what your institution is, how they're testing it, right? Are they using the Abbott, the Roche, the Simplexa model? Because all of those have very different false negative values.
Yeah, I do think, just to emphasize the point again, yes, absolutely, there are false negatives, and yes, absolutely, a negative test is still treated with the same PPE, with the understanding that there's a pretty decent chance that they could be an asymptomatic positive. And that's probably going to carry on for some time until all of these testing questions are clarified, or until we have proof that we have less COVID in our communities. So the second part of the question about the IgG, will they be considered post-infectious and immune? We hope so, but we don't have data to support that just yet. So as this serologic testing is used more and more, we hope that that will be proven, and that we can use those tests to help guide us in terms of selection for patient care, and even for the healthcare workforce. So any recommendations for COVID testing prior to nasal laryngoscopy or nasal endoscopy, assuming that means in the office setting? And so that's a tricky question, because what goes into that question is the availability and feasibility of testing. So in an ideal world, we'd be able to test anybody we wanted and have results when we wanted, and then carry on, and the test would have such great specificity and sensitivity that we'd be able to trust it. Currently, we don't have that level point of care testing available to us. And the current approach is only do those procedures if you really, really need to do them. Of course, if we want to get back to near normal or normal otolaryngology practice, where we do perform a lot of laryngoscopy, endoscopy, and nasal endoscopy, that will become a bigger question. At this point, the best advice is N95 and appropriate eye covering face shields for any patient, because even if you did test them all, as we just talked about in the previous question, current testing carries close to a 30% false negative rate. So with that, that brings us to the end of the hour. We apologize for some of our technical difficulties tonight. We hope that this was enlightening. We hope to continue with the webinar series and dig a little deeper into management of the office as we increase our patient volume into the office. And of course, we're always interested in your feedback. So if you send in a reply to the email. And finally, we're still here and open to help you care for your patients. So thank you again. Everybody have a good night.